Welcome back. Even if
Welcome
it's just
back to what?
a cup of tea. Yeah, welcome back to
Who are we welcoming back?
second wave.
Second wave chat with Dr. Sonia and Dr. Ed.
Welcome back, our friend COVID.
So last time we spoke, a few weeks ago, we pretty much didn't have any cases really.
We haven't had any on ICU for about 2 months, up until the last 3-4 weeks. And now they're coming in again.
So, I mean, we can conclude lots of people are sceptical whether we would have a second wave, although all the evidence kind of...
I think we're in the second wave. I think to put it in perspective, the first wave, there were about 3,300 people in ICU across the country. Today,
at the peak,
yeah, on the worst weekend, which was Easter weekend. Today there's 507, which may not sound that much, but that's the equivalent of about maybe 25 ICUs full of patients with COVID.
And there's a lag, isn't there, about people.
Yeah.
So many of the people that you're going to see in ICU already have been infected over the last few days. But, you know, we often see people come into hospital sort of day 7, day 10.
Of their illness, plus there's the incubation beforehand. So it could easily be 2 weeks from the time that they're exposed to COVID before they get referred to me on ICU.
And that's why it's really important that I know the government have increased the kind of lockdowns. I know they did the rule of 6 last week, but now they're increasing this tier system.
Tier 1, tier 2.
So what's been happening out in the community with the R number then, and how can we...
So the R number, that gives us an idea of the of how quickly it's spreading, really. So if you've got an R number of 1, I'll get my little Lego people out, then this little Lego person, if she gets coronavirus, and the R number's 1, she's going to pass it on to one other person, okay? Mm-hmm. And he's going to pass it on to one other person. So it's a fairly controlled spread, but what we're seeing at the moment in the community is the R number seems to have gone up to somewhere between about 1.3, 1.6. So if we took, for an example, if the R number was 1.5 at the moment, then this little chappie, if he gets coronavirus, he's going to give it to 1.5 people. Okay?
Is that half a person?
That's half a person. See, it's got no legs. So that 1.5 people are going to give it to another 1.5 people, which doesn't sound like it's spreading too quickly. But after it's spread 10 times to 1.5, 1.5, 1.5, and each person's spreading it further and further, that means that 58 people are going to have got coronavirus from our one little bloke who had it. That's what an R number of 1.5 looks like. It's quite graphic, isn't it? When you look at that and you look at all these people and you think, wow, that's from one infected person after they've passed it on 10 times, if the R number's 1.5.
And we know of these people, most of them, I think around about 80% will still have that mild disease. But then a proportion of that will then come into hospital. And that's what we're seeing now. So that explains why 3 weeks ago we weren't really seeing anyone. And now we're seeing people coming into hospital. Yeah,
absolutely. Of this 58 people, you know, it may be reasonable to assume that perhaps 8 of them are going to come into hospital. Okay, that's 8 beds we've got to find. Hopefully they'll all settle, but it might be that 1 or 2 of those come to ICU. So,
and of them, you said not all of them fare so well.
No, they're not all going to make it out. It's still, the statistics for people that get into ICU and need a ventilator are not good. You know, your chances of dying if you need a ventilator are still in the order of 30-40%. So it's really not where you want to be.
Okay. And so this assumes an R number of 1.5, and obviously there are factors affecting how quickly a virus spreads, how contagious it is. Lots of that's intrinsic to the virus itself, but obviously a lot of it is how society reacts to it as well. And I know the R number, you know, this is 1.5 considering all the precautions we got in place, and that's why we're having to do, you know, stricter precautions at the moment, stricter lockdown stuff. But I know in the past it's been higher as well.
Well, yeah, I mean, in the first wave, in some areas, it was thought that the R number was as high as 3. So, you know, if one person had it, they'd pass it on to 3 others.
And it does. I mean, it sounds like a lot, doesn't it? Each of
those would pass it on to 3. So you can see already we're getting a lot more people. And if you look at 10 pass-ons from there, this little one bloke with his coronavirus could have passed it on to 59,000 people.
So instead of like 59 people, 58-ish people, we're looking at
59,000.
And that goes from an R number of 1.5 to 3. So just by doubling the R number, you're massive magnitude increase. So as a kind of representation of that R number then, the R number of 3.
Yeah, I don't have 59,000 minifigures. Lego, if you're listening.
Sure? I think we could have a whip round. We get close to it.
We could probably get close with a whip round, yeah. No, we thought we'd do it in bricks instead. So, here's your one brick. If you imagine what 60,000 bricks looks like, that's actually quite hard to imagine. Probably the easiest way to do it is think of one of my biggest models. So if we take, for example, the Hogwarts Castle, that has, I think I'm right in saying, 6,020 bricks.
Right.
I think, Justin, you can correct me on that one if I'm wrong.
So of 10 iterations.
So if you imagine 10 of the huge Lego Hogwarts castles and all the bricks that went into that, that's how many people would have coronavirus if the R number was 3 and one person passed it on 10 times.
So it'd be 10 of these castles in bricks.
Whew. It's a lot of bricks. So we've got to get the R number down. And all of the social restrictions on mixing, on being too close to each other, it's all aimed at trying to bring this R number down so that we can't stop coronavirus. Wouldn't it be lovely if we could? But I think we know that we can't stop it in its tracks. But what we can do is keep the numbers low enough that we can cope in the hospitals, and therefore you can have confidence that if you get sick with COVID, there's going to be room for you, and also that if you need care for something else, that we can also provide that care without having to delay it.
Another thing I'm hearing lots of people talk about is whether the virus is less virulent, so less severe now.
Oh, yeah.
Is that true?
No. So I can only talk from my own experience of treating patients, but it really hit home. We've all been nervous about the second wave. I don't want to do it again. It was horrible, and I'm going to have to do it again. And all of my staff are, and nobody wants to, and everyone's a little bit scared, and we don't want to do it. The first COVID patient I had in of the second wave was someone who was fit and well, who I admitted to the ICU, and the first 3-4 days on ICU, she did fine. And then she developed failure of all of her organs and she died. And she died in a similar way to all of the other patients that I saw die of COVID. And as an intensive care consultant, to watch someone die of a disease that you still don't entirely understand is it's disturbing. So no, unfortunately, I think this is the same disease, and what I've seen of it so far in this second wave, it's not milder.
I think what some of those rumours might have come about is that obviously people have been relating it to the flu ever since we first had it, both in a way to kind of help communicate what the disease is, but also in a negative way, I think, to kind of miscommunicate, misrepresent what the disease is. And as we know with the flu, we can have different strains each year, and they can be sort of severe strains or not. And I think people are just hoping more than anything, aren't they?
I think, yeah, absolutely. And I mean, as we're learning more and more about this all the time, there's suggestions maybe even that 85% of people that get infected have no symptoms at all.
Yeah, and that may also be why people think it's less severe, because maybe we're just categorising more people who have it, collect it, and then so we're coming up with a conclusion, which we always thought all along, didn't we? That actually the case fatality rate is always going to go down
because we're testing more people. I mean, if you look at a lot of the people being tested at the moment, it's school children, because a lot of schools are insisting on tests for children who've got colds before they're allowed back into school to prove it's not coronavirus. University students, there was one university in the UK, 770 positive tests out of 1,000 students in a hall. I think out of those 770, less than 10% had any symptoms.
Right.
So that's great if you're young. The problem is there's the odd young person that gets it and does die, and young people go home to older people. And we're already seeing, unfortunately, the death rates in particularly those over 85 are beginning to mirror how things were in April.
And in terms of the mutation as well, so a lot of people are saying we would expect a virus to mutate over time, like kind of all living things do in a way. Are we seeing much in the way of change in the virus?
Well, that's a real good focus of what's going on, because obviously we're trying to create a vaccine, and in order to create the vaccine we need to know exactly how the virus gets in the cells and all the rest of it. So if we take our good old coronavirus again, if we look at the RNA, the strand of RNA that sits inside, then all of these little parts of code that are on the RNA, they can switch around a bit. So yeah, this one might not be there anymore, or it might change place and might come in here, for example. Those little mutations occur, and they occur a lot, and we're definitely seeing them occurring in this coronavirus, but they don't seem to be very relevant. The things that are important are if you get mutations in certain areas of the coronavirus. So for example, the way the coronavirus gets in the cell is this spike glycoprotein acts like a key in a lock on your cells, and it unlocks the cell such that the coronavirus can get in and it can multiply. There's no mutations occurring of this spike glycoprotein. That's staying the same. So to all intents and purposes, no, it's the same virus. These little tiny point mutations, as we call them, they're useful because they let us track the coronavirus around the world. And we can see that, for example, there are slightly different mutations occurring in different geographical regions, but that doesn't translate through to a different clinical picture. It's still coronavirus causing COVID-19.
What has changed then? How do we feel on the ground about?
Yeah, so we've got we've got results of the first trials that were done. We had huge numbers that we managed to recruit into the recovery trial in the UK, and that showed that dexamethasone is a good drug to take if you're really quite unwell with coronavirus, but can be harmful if you're just mildly unwell, which is interesting in the context of Trump taking it.
Yeah, and it was and it kind of fits this kind of two-part picture of COVID, isn't it? The initial infection and then your body's immune system to it. So
I mean, the dexamethasone, a steroid, is aimed at trying to decrease the inflammation or the response of the immune system. So it would make sense that if you took it early, it's not going to be helpful and maybe harmful. But when your immune response has kicked in and is actually causing damage, then dampening that down might be a very good thing. Mr. Trump tried a whole load of other treatments as well. There was the antibodies and various drugs that are aimed at trying to stop the virus from replicating. We don't really have trial data yet to advocate those to be used widely. So although we've got some understanding of the disease now, our treatment options are not that far forward compared to April. But we do know how to ventilate people better with this particular disease. We do know that blood clots are a really big problem. So we're thinning the blood in people much earlier than we were before. So I think from a hospital point of view and an ICU point of view, from the in terms of treating patients, I think we are further forward. I've certainly got less anxiety about that than I had last time. The first time around it was all, oh my God, how are we going to cope with the numbers coming through the door? But I think we are a little further forward. As I say, there's still issues with staffing, and that's a really big deal. You need really skilled people to be looking after these patients. And remember that those staff are putting themselves at risk and may have vulnerable people at home. So staff isolation rates is going to be high. The real worry, obviously, is that we're running into the flu season. I've not yet seen a patient with influenza and COVID. I'd rather hope not to, because to me, I can only imagine that's a really bad recipe. So please have your flu jabs. It's a really good idea.
When you're talking about treatments as well, it's important to note that obviously we know a lot of stuff that doesn't work now that we didn't before, because people had lots of ambitions with lots of different drugs, and we can kind of put them to one side. So that is progress.
I think we can put the bleach to one side. I think we can probably put the UV light injected to one side.
But we joke about some of the other things that are kind of being used at the moment, but they're important trials to be had, though,
Yeah.
aren't there? You know, drugs that we know are relatively safe and indicated in other conditions, they're great ones to
Yeah, I
form
mean,
part of these trials.
some of the HIV drugs which are aimed at trying to stop the virus from replicating, they haven't really come good in COVID. But that was a really good question to ask because, you know, there was the potential there, and there'll be the potential for similar drugs to actually be quite useful. So negative trials, I think, are just as important as the positive ones.
Yeah. And historically as well, we've always had trouble with antivirals.
Yeah.
Really, I mean, how do you kill something that isn't alive? You know,
Yeah.
that's the thing, isn't it? Like antibacterial, you know, antibiotics. We've always kind of had something in our back pocket, but viruses.
Yeah, and the production of these things is hideously expensive. And, you know, look how long it's taken us to get on top of HIV. You know, we've now got really effective drugs, but it's taken 30, 40 years to get there. So let's hope that a vaccine comes along sooner rather than later. The first time around, there were concerns about whether we would have enough ventilators, and various companies went into rapid production.
Overdrive. That seemed to be what everyone was talking about, wasn't it, initially?
I know, but the whole ventilator argument, you know, that's like going up to a starving man and saying, it's okay, I've got a menu. A ventilator is no good to anyone without the staff to use the ventilator and the staff to care for the patient that's being ventilated. And that's largely the intensive care team.
And you can't just suddenly go into manufacture of this. And I know we have, in a way, trained up more people, haven't we?
We put a lot of people through basic training. And we were hugely blessed first in the first wave to have so many staff just literally come and say what could they do to help. This time around we need to keep the elective services going as well, and that's really going to stretch us a lot. But as well as that, you know, aside from are we prepared from a medical point of view, there's the are we prepared from a social point of view?
Well, I think people are kind of getting a little bit itchy now in terms of the public health thing. I think people have kind of had enough. I'm seeing a lot more resistance to things like the lockdown, like local lockdowns, wearing masks and that type of thing.
It's tough, isn't it? Because people are going to have less money. The furlough scheme coming to an end to be replaced by something that provides less of the income than people were getting before. That's going to start to really bite. Obviously, there's the two sides of COVID. We need to protect health, clearly. But by protecting the public's health, there's no doubt we're harming the economy. So we need to kind of get the balance on that, and that's something for our politicians to do, and I certainly don't envy them that job. But yeah, you know, I mean, it's pretty tough, isn't it? The students going off to college, not being able to go out and, you know, to a nightclub.
And I think in many ways we had it at a good time in the summer because
the weather was good.
The weather was nice. You know, we've seen hits on terms of mental health as well, and other people's physical health in another way. So
and we know that over the winter people get lonely. A lot of people are kind of shut indoors and they get lonely. So I'm really hoping that we bear that in mind for all our neighbours and elderly relatives, that you know, they're going to need to have some very regular contact to keep them from feeling that way over the winter. I think there's no doubt it's going to be a much longer wave than the first wave. With any luck, it won't reach the peak levels that the first wave did, but it's hard to see that this isn't going to be around for, you know, for months. I guess the only way that I think about that is, well, the longer it's around, the more people that get it, the more people that are hopefully getting some immunity to it, which means that hopefully, you know, the damage that coronavirus is doing to the human race will be nearer to ending.
I know I did that video last time when we had a chat and Q&A, and everyone was like, will Sonia be on the channel again? And
Here I am.
There we go, straight away.
Yeah, I'm not going anywhere. I'm sure we'll do a few more.
Definitely.
Yeah.
Okay, thanks for watching, guys. So until next time.
Bye.